Thanks, Joe. Kyle's threatening to throw tomatoes at me, so look out for any red things coming across the stage. Good morning. Happy to be here. Thanks, guys, for the invitation. It's lovely to be back in San Francisco. My assignment is to talk about posterior walls. I saw Kyle ask you all who's doing acetabulum. Sounds like not many, so we'll try and make this relevant for the surgeons who want to understand indications. So no financial disclosures. I have used a few slides from friends of mine, though, to make the points. It makes better teaching. So posterior wall fractures, we're going to talk about them, some case examples, walk through the surgical approach, and some of the details you might think about as you're looking at these. So long time ago, this is my homage to data. We generated some data a long time ago doing mechanics, basically showed posterior wall fractures are bad. They disrupt your articular mechanics even when you put them back normally. So the indications for treatment, basically taking, I agree with everything Kyle said, but summing it down for the posterior wall, really it comes down to instability and incongruence. And incongruence you assess out of traction, and it could be that there's an incarcerated intra-articular fragment, or it could be that there's just instability in the joint. But you have to look carefully to see if you have a non-fitting joint. We'll talk about that in a second. So if there's any question, consider an intraoperative stress exam. So radiographic assessments are useful to identify posterior walls. There's 3 or 4 different articles out there that look at ways to assess the posterior wall, and what they all say, each one of them says, if it's really small, it's not so bad. If it's in the middle, it's a gray zone, and if it's really big, they're all unstable. And so depending how you measure it will depending what the numbers are for what's big and small and so forth. But you get the idea that you need to think carefully about this. So they all predict instability with big pieces. Now, if you have a retained intra-articular fragment like this little white thing in the middle of the joint where the joint is perfectly congruent, that's okay. Oftentimes, that'll be a remnant of a little chunk of bone that's perhaps pulled off on a ligament and flavum. But if the joint's stable, that can be okay. So here's a first case, decision to operate or not. So here's a CT scan looking at this. It looks, if you look at it in the orientation of the fracture, the articular component of the posterior wall is kind of small. So you might say, is this something I'm maybe worried, maybe it's intermediate, should we or should we not be worried about stability? So here's an example of how to do an intra-articular exam. This is Alan Jones, actually, so I borrowed these slides from Alan. They're very nice. But we can see our exam on the AP, so we'll look in different positions. So on our AP view, we'll give some axial loading. We'll flex and look at different positions of flexion, adduction, internal rotation, looking for the operator oblique, looking with flexion and external rotation. And so in each position, what we're seeing is a stable position of the head, so the head is not deviating and moving out. So this is a stable hip. So this is a fracture that could be treated clinically, non-operatively. And the 3 months follow-up, which this one did come back for 3 months, had a pretty good result. Now here's a different case, second case, a little bit different decision, and even perhaps maybe a smaller posterior wall, but it's more superior. And superior walls can often be deceivingly unstable. And so in this particular case, you can see a stress exam. Here's an AP, here's a flexion, and notice the gap between the femoral head and the acetabulum. So this is clearly unstable. So this one is an indication to be treated, even though the fracture itself looked a little smaller. Now, in terms of those decisions, we think about congruence, about fracture displacement or loose bodies, and about stability. And so the identifying where the pattern is and where it goes becomes very important. So size isn't everything, but it can be important. So here's a third case. This is sort of the young traumatologist's dream case. This is a young man, good bone, had an isolated injury, and if you look critically, you can see there's this gap in his posterior wall. So he has this defect in the posterior rim, and it continues up. You can see it on the shadows. When we look on his operator oblique, again, we can see his displacement of the posterior wall, and you can see this defect in the articular surface. And see the opposite side is really, the joint looks pretty good from the iliac oblique because all the other structures are still intact. So we look at the CT scan, we see this large single piece, again, ideal for young traumatologists hungry to fix something. And so how would we do this? If we choose to take it on, we're going to do a Coker-Langenbach approach, which is very analogous to the standard posterior approaches most everybody else does for total hips, but they're a little bit different in terms of the operative details. Personally, I think you can do them either lateral or you can do them prone. A lot of these I will do prone, and I know that's foreign to many people who don't do specifically acetabular fractures, but you can do them lateral. So here's an example. Here's some slides demonstrating the outline of an approach to a Coker-Langenbach, so you get the orientation of the patient here. And so there's the Coker, there's the Langenbach components. And so as we open up deeply, what we'll find is there's a trochanteric fossa, and then there's the bursa rather, and then the gluteal sling, which I typically will release. And I'll identify the piriformis tendon, the sciatic nerve, and then the gluteus medius, so all anatomy that you're familiar with. The difference between the standard posterior approach for hip replacement and this approach is our aim is to do much more dissection around the posterior part of the bone. So we're exposing the bone of the posterior socket, not so much the interarticular aspect like you would for a hip replacement. And so in normal anatomy, we can see the piriformis tendon. You can see its relation to the sciatic nerve. And here's an example of a bifid nerve, and you can see the tendon going through it. I would say, in my experience, the patients who've had the worst sciatic nerve palsy from the injury are the patients who had a bifid sciatic nerve that had an avulsion of the piriformis when you actually got in there. And you can understand why that would be so detrimental to the sciatic nerve looking at this. So and then there's a conjoined tendon, which is the next step down. My mnemonic for the short external rotators is P, go, go, Q. So the piriformis and then the gemelli just below that with the obturator internus. And so the obturator internus tendon is important. This is one of Emile Letronel's big teaching points, was to identify the obturator internus. And then as you reflect it up posteriorly, what you'll see is this white bursa of the obturator internus tendons. And that lets you know that you have reached the lesser sciatic notch. So that's one of the aspects of exposure posteriorly, to make sure that you understand you're all the way back on the retroacetabular surface to the greater sciatic notch. And then finally, we can elevate the gluteus minimus off the posterior wall fragment. And so here, for example, is an example of a posterior wall just under the retractor there. And now we can see it's been fixed, so we have our plate and screws. And so in this case, here's our fixation montage for this particular fracture fragment. You can see it there, and then with post-op CT. So posterior wall worked well. There's this concept of marginal impaction, which you can see in many fractures. You happen to see it in posterior walls as well. And it's illustrated in some of these pictures where you can see that the femoral head is pushed against the articular surface, and it crunches the cancellous bone. So cancellous bone is kind of like a styrofoam cup. You know, you crunch it and it doesn't bounce back. And that's the way cancellous bone works. So you impact or crunch the cancellous bone and it doesn't bounce back. So we can see here's an example of intraoperatively, we're in prone position in this case. You can see the orientation of superior and anterior. So we see the impacted bone superiorly, and you can see the femoral head sitting there, the white stuff just below that. And so we're going to reduce it to the femoral head as a template using different techniques. Here's an example of a spring plate for a small piece of posterior wall that might be too small to put a screw into, but yet we can hold it in place using a construct to help stabilize that. So here's an example of a marginal impacted case. We can see the marginal impaction here. Intraoperatively, we have our reduction clamp on. Now this is a reduction clamp. This is the line of the posterior wall that's reflected to get us to the joint. That's where the femoral head is sitting in a prone position, sitting in a reduced position. And then there's our marginal impaction. We need to push down and model to the femoral head as a template and then graft behind it as we're fixing. So then here we are post-op, and quite often, even though we try our best, as Kyle said, make it perfect as best you can, sometimes there's still small articular defects left over. Last case, this is a variant of a posterior wall that's important to recognize that extends superior to the acetabulum. So if we look at these different views, you can see how unstable the hip is, how it's migrated superiorly. We look at our CT cuts. And so when you draw this out, you can see a fracture like this that extends well superiorly. It's just a posterior wall, but that doesn't mean it has important variations to it. This is an excellent indication for a so-called digastric osteotomy, where you make a cut in the trochanter, but it's still connected distally to the vastus lateralis and still connected proximally to the gluteus medius, so that we have good stability ultimately in the trochanter, but it allows us access to the superior acetabulum, so that as we're thinking about the fracture we were just looking at, we can reduce the head and use a construct to help stabilize that particular pattern so that we can stabilize the posterior wall. If you look at posterior wall outcomes in general, they're very dichotomous. Either they do really well or they don't do well at all. And generally, the mean time to failure is about 1.5 years. So within the first 2 years, you will know whether your posterior wall is doing okay or not. So in summary, posterior walls are common patterns. We've talked about the instability and incongruence as a indication, and marginal impaction and the importance of really identifying. I think for this fracture, for most surgeons, if you can expose the fracture and understand the anatomy, you can fix it. Thank you.